Dear Facebook Pure Urology viewers, good evening one and all. As you all know that we are doing surgical technique based presentations one or the other day. So today we, even though not discussing about the surgical technique based presentations, we will be focusing on how the evolution of surgeries in urology has happened. For that, one must be senior, one must be well versed with the open surgery, one must be keep on going seeing the transition from open surgery to endourology, and the same surgeon must be seeing the development towards the laparoscopic surgery, and the same surgeon must be developing the robotic surgery. To my knowledge, very few in the world will have this opportunity to start with the open ureteral lithotomy, open radical prostatectomy, multiple open major complicated cases to the extent of most advanced robotic surgery now. It needs minimum 40 years of experience. One such topic today is institutions, particularly government institutions, their role in making the young urologists according to the need of the hour, how to train them right from the ethics up to the latest knowledge. We have the speaker, professor, my mentor, Dr. Arup Kumar Mandal sir, so-called AK Mandal sir from the ex-PGI Chandigarh, and presently he is at All India Institute of Medical Sciences Rishikesh branch. Before I read the curriculum vitae, I wanted to say that I have been trained in All India Institute MS and I have got training in PGI Chandigarh, but in urology we started from the zero because I did not work any other place, and whatever the skills we acquired and discipline we acquired, we are able to replicate and do this much in private practice also. With this introduction, I like to officially introduce through this PPT about sir. This is Dr. AK Mandal sir. Today talk is traditional to modern urology, how institutions marched ahead during 4 decades. Most of his talk will be about PGI, but he is also well known about the aims and all the changes that happened in Manipal, CMC, Vellore, because he belongs to that era where the professors have started their career. Dr. Mandal is Professor of Urology at All India Institute of Medical Sciences, Rishikesh, Uttarakhand, joined PGIMR Chandigarh as a postgraduate student. This is what the most important. The place where he did MS General Surgery, he retired establishing the robotic technology at PGIMR, which is 37 years of journey. 37 years of journey. Way back in 1982, he joined MS. He started career in urology as an assistant professor, Department of Urology at PGIMR Chandigarh in October 1988, served the department in various capacity before taking up its reign in February 2004. During his tenure of his leadership, the Department of Urology at PGIMR Chandigarh witnessed upgradation to Advanced Urology Center with modern equipment. This exactly happened when I was leaving. I left PGI Chandigarh in 2004, improved services and training infrastructure with a supportive team of competent faculty members and other category of staff. He led the Department of Urology to establish the robotic surgical facility of PGIMR Chandigarh in 2014 and put the institute in world map. That is a major change under his leadership. Even though he was very good open surgeon and want to traditionally teach open surgery, he accepted the change and invited this change and dedicated one department for that. His youngsters, very much juniors like Ravi Mohan and other department like Santosh, Dr. Uttam, Dr. Mayank have worked with them and developed the department of robotics like anything today at PGIMR. He authored over 250 papers in peer-reviewed journals, some of which are quoted and referred to in Campbell's textbook of urology. With this introduction, I wanted to ask the questions and then go to the, if at all any presentation is there. Sir Mandal sir, thank you for accepting the invitation. Good evening, sir. Hello.
Yeah, very good evening.
Yes, sir. So am I audible, sir?
Yes.
Yes. Sir, my first question is, when you joined Master of Surgery in PGI Chandigarh, who was your mentor in general surgery? Who was your HOD, sir?
Professor Kuldeep Singh. Professor Kuldeep Singh. Professor Kuldeep Singh was the head of surgery at that time.
Sir.
And I worked under him, and the other professors were Professor S.K. Khanna, who used to do a lot of hospital surgeries, Professor R.N. Kataria, who used to do endocrine surgeries, thyroid.
The main idea of today talk is the youngsters are aspiring for the robotic laparoscopy. As we all know, we also were not trained so much in laparoscopy when we finished our MCH. When we went for practice, we faced a lot of problems. So we want to listen from Mandal sir that what type of training all the government institutions may not have the same. So we wanted to listen from Dr. Mandal sir how this institutional training make a difference. That's why we wanted to have a brief history of the Indian urology in the Chandigarh as well as All India Institute or the other institute also. Mandal sir, you are listening? Okay, we will quickly continue. Sorry audience, there are nearly 30-40 audience online. So we will continue, sir, please.
Sure.
Sir, after your MS General Surgery, when you went to the urology, you have gone with interest, or urology was crazy that time, like that you have gone? You developed interest in urology?
I developed interest in urology, and there was only one seat. I made it a point that I compete and get it.
Get it. Okay, sir. That time who was the HOD, sir?
Professor Bapna was still there. Professor B.C. Bapna.
Sir.
Still there. And the other faculties were Professor S.K. Sharma.
Yes, sir.
Dr. S. Vaidyanathan and Dr. A.K. Goswami.
Sir, Professor.
Before Professor S.K. Sharma.
Yes, sir.
Dr. S. Vaidyanathan and Dr. A.K. Goswami.
A.K. Sir, Vaidyanathan sir, he did his urology training from which
A.K.
place?
Goswami.
Yeah, A.K. Goswami.
From PGI Chandigarh. Dr. Vaidyanathan was trained MS and MCH at PGI Chandigarh. Dr. Goswami did his MS, I think, from Jabalpur, and he did his MCH from PGI Chandigarh.
Okay. So, Vaidyanathan sir, area of interest?
His area of interest was totally neurourology.
Okay.
He had a lot of works with the paraplegic patients, and his thesis
yes, sir.
was on urodynamics. I must tell you that the first urodynamic machine in the whole country, in India,
yes,
came to PGI Chandigarh, and that was procured for the PhD thesis of Dr. Vaidyanathan. I think it is 1978-79.
So, Professor Vaidyanathan, next to Professor Vaidyanathan is S.K. Sharma sir or Bapana sir?
No. Professor S.K. Sharma was senior to Dr. Vaidyanathan. Dr. Goswami was junior to Dr. Vaidyanathan.
Okay. So, what were the surgeries in the OT list daily? Maximum list is what? In those days, if you take as your residency, what was the OT list maximum, sir?
One table used to be TUR prostate or TUR bladder tumor.
Okay.
The other table used to have the reconstructive surgeries or stone surgeries.
Open surgeries?
Yes.
Okay. So, by the end of your third year, what were the surgeries you are familiar with?
We did only 2-year MCH. We didn't have a 3 years course that time.
Okay, sir.
And of the endoscopic surgeries, lower tract endoscopy, bladder tumors, prostate, endoscopic management of strictures. Others are stone surgery, pyeloplasty, stricture urethra, VVF repair. Those were the common open surgeries.
For very large stones intrarenal, what used to be the surgery mainly opted for the patient, sir, if it is functioning?
That time we used to do a lot of anatrophic pyelostomies.
You used to
Maybe
put
with,
cold ischemia type?
yes, we used to cool the kidney. We used to clamp the kidney. After clamping, we used to cool the kidney with ice slush, and then we used to do the nephrotomy.
Okay. So after the PGI Chandigarh, did you go to, you are from Bengal, why you did not go to Bengal, sir?
Well, after my MCH training was over, I was keen and prepared to leave PGI to work in other place.
Okay.
Bengal, I did not decide because the somehow the working atmosphere in Bengal was that time not very congenial because of the political disturbances.
Okay. Okay.
So happened that I took full job and I was ready to move to AIMS New Delhi. But some Professor Sharma, by the time Dr. Bapna retired and there was shortage of person in the department, so Professor Sharma said, stay on for some more time as a senior resident.
Okay.
And during that staying period, the opportunity came, I applied and I was selected as an assistant professor.
So you continued in PGI?
Yes.
First PCNL and URSL was done in which year, sir, during the PGI?
URSL came earlier. I think we got an urotoscope. This was initiated by Dr. Bapna, but it came after his retirement. The equipment came in 1988. But I like to say that the first rigid uroscope, and it was a diameter of 12 inch. It had an outer sheath and detachable telescope.
Yes, sir.
So we did not succeed doing any urotoscopy with that urotoscope. Later on, the semi-rigid urotoscopes were introduced and we started doing it 89 onwards.
Sir, my first important question starts from here.
Yes.
All the students who come want to do the latest which is available in CMC Vellore, SGPGI, AIMS and Chandigarh. How you are such a good open surgeon and hypospadias surgeon. When things are getting converted into endourology, what was in your mind, what was there in the PG's mind, how it used to be satisfied?
Well, PGI has been a teaching center.
Yes, sir.
So PGI is the third institute who started the MCH course in the country.
Sir.
Okay, so therefore we always try to remain updated in the training facilities.
Yes.
We used to make it an effort to remain aware what is happening in the world, what is developing, and tried to procure the equipments and introduce the technique in the department so that students are exposed to it. That was our intention.
Sir, my second important question, in PGI in the first year, we will be working very hard on the basic principles like the pressure in the kidney, pressure in the ureter, anatomy of the ureter, anatomy of the prostate, urethra, curvature of the urethra, basic instrumentation, damage, all these things. In the present era, when directly you are going with flexible scope, directly you are going for laparoscopy, do you think in Rishikesh, all the first years are still taught in a standard fashion through the journal club which was there in PGI? Is it continued? Do you think that is essential even in the present era, also talking about basic articles of anatomy and physiology before they take the knife and cut?
It is extremely important, and we try to do even the same thing at Rishikesh. However, because the more number of cases are being done by non-open methods, endoscopic methods, so
Okay.
there is little difficulty in learning. I must say that.
Yes, sir. Sir, we were taught how
The
to
anatomical, please say it.
we were taught the rib cutting incision pleural closure if that happens. Are the residents are getting chance to see the pleura and rib open method now?
I must say very little. I am here more than a year now. During this period, I think less than 5 open nephrectomies has been done. So therefore, the exposure to open surgery is very limited in these days. This is happening everywhere. AIMS case, PGI Chandigarh, and all other teaching institutes.
Sir, in that case, if any patient gets emergency bleeding during nephrectomy, if you don't know confidently retroperitoneal opening or transperitoneal and reach the IVC, even if he has done 100 laparoscopic surgeries, what is the fate of the patient and how do you feel in training now? Because you have still a decade of time to teach. How this transformation we have to understand?
It is always my emphasis that the students are oriented to open surgery. So purposefully, I even now today tell for a large ureteric stone, you do open ureterotomy, you should do open prostatectomies, you should do difficult kidney tumors by open approach, although you can manage by robotics. So unless the students are exposed during their training, this will be difficult, no doubt about it.
And I have seen you doing radical nephrectomy in a meticulous manner in the sense you ligate 2 stitches with silk, the choroidal vein, 2 with adrenal vein with proper dissection of 1 centimeter length and take a proper Metzenbaum scissor and cut with half centimeter margin. What is the role of that square knot, single hand, double hand, and putting a proper square knot, 3 knots, and then dissecting plane by plane? Everybody is using cautery or clip, but as a surgeon, one day or another day we may need to repair or suture something. Then in reconstructive urology, as the days goes on, how will they do redo surgeries if those type of knots are not practiced from the surgery?
See, whatever you mentioned, those are the meticulous ways of doing things. Because we have been trained like that, even today I do the same thing.
Yes, sir.
These days, you have the access to the various clips which are quickly applied and easy access. Open reconstructive surgery is very rarely being done because nobody will do a pyeloplasty nowadays. Either you do laparoscopically or take the help of a robot. Open pyeloplasty, everybody will hesitate.
Yes, sir.
So those are the lacunae of training, at least for the students.
Yes, sir. Hello.
Yes. Ask me.
Yes, sir. So in that case, any surgery which requires open intervention, for example, if we have to do augmentation cystoplasty, and if you are reoperated and if robotic is not possible, how they will approach and do hundreds of stitches on the intestine if you don't have a basic training on the open surgical knots, open surgical methods. Forget about
Doctor, whatever you are asking are very pertinent questions. So the open surgery has been reduced to something, I will say, less than 10%. If you take everything, open surgeries are reconstructive urethroplasties or hypospadias or vaginal VVF repair. Those are the standard open surgery these days here. Others are like the following cystectomy, you are doing diversion, people are trying to do by intracorporeal techniques. So those are little too sophisticated. I think it's not the place in our country. I still insist that we should do open diversions So therefore, students are still exposed to handling the intestine by open method. I must say that whenever the surgeon gets an access to a stapler, he will fire a stapler and finish the anastomosis quickly, not the hand-sewn anastomosis.
In this way, I am opening to a newer subject, that is, in Western countries, whatever your technique, first 3 years during FRCS, even in US, they have to undergo intense basic surgical training where you have to practice many times open surgery methods, whereas the DNB training in private institutions, even if it is surgery, even if it is DNB urology, are directly going to the theater watching the advanced surgeries and then taking the rounds and then going home thinking that they are doing great surgery. Is it not a big hamper for the future generations to treat the patient safely? At your very high post as HOD in Rishikesh, what is a take where DNB students are following the professor? They know all advanced surgeries, but from the beginning they are not trained systematically about the physiology, anatomy, and surgical principles.
This is a big problem. I'll come to one about the skill acquisition of putting sutures and handling tissues. So skill labs will come in future, no doubt about it. Here in AMCC case, there is a surgical skill training lab, So with the help of mannequins, they are taught different techniques. We have got a ultrasound guided puncture, whereby you can make the students to learn about the selecting a particular calyx for puncture. So we are also trying to develop some kind of modules so that the students are given certain basic exposure to the very basic techniques before they go on to the surgery. Now, as long the rush of patients are there in our country,
Sir,
possibly students will get exposed and get learned, but in their generation, like those who are students now, when they become middle age, they will have become problem, I'm sure about it.
yes, sir. One more, this is a problem to the patients also, not only for the
Yes.
doctors. Patients,
Yes.
my grandchildren may not get an open surgical access when they have patients, not the doctors.
Yes.
One more subject of interest is in your training. You have seen many of the students have gone, they excelled in general urology, some excelled in some specialties. What should be the initial mind makeup for the MCH passed out urologist? Should from first day onwards to subspecialty, or 3-4 years you work with a good senior, get access to all the things, then go to super specialty? Which way is better in the present era in India?
This is my personal opinion,
Yes,
the
sir.
urology training has been started in India in 1965.
Yes, sir.
So it went on for 2 years course, because 2 academic years, because the syllabus was less, the area of work was less. In late 90s or in around 98, 2000, it became 3 years course.
Yes, sir.
Nowadays, urology has developed into so many different specified subspecialty areas.
Yes, sir.
So therefore, it's the time for the students to choose his area of interest. Now, problem is, after doing MS and then MCH, you already spent 3 years
Yes,
of
sir.
your career. Then if you need to spend 1 or 2 years to do the specialization, you will lose some time of a career. It is not possible for everyone also. So my personal suggestion is, it's the time to review the curriculum. The course duration may be starting soon after MBBS. We may not need general surgery. See, what we need to learn is the management of the wound, emergency and trauma exposure, critical care. So from the surgery curriculum, only these things should be taken. Rest should be urology.
Yeah.
I will propose, given a chance, to augment this course to a comprehensive course of 5 or 6 years. If I make it 6 years, after MBBS I'm talking.
Yes, sir.
If I suggest 6 years training, the last year should be a chance to do kind of fellowship.
Yes.
He can choose by the end of 5 years of training and maybe exit exam can be held after 5 years. So he has got one more year to get his degree. This 1 year he can utilize for his area of interest.
Yes, sir.
That's my proposition.
Yes.
Actually, we are working on it. We are working on it.
Because in future you may be involved in the government policy decisions because of your post. Let us hope such things happen, because since long time no change has happened for last 30 years in the training module of the medical field. Anyway,
Yes.
sir, coming to the research work, we also were there, but somehow even I am feeling bad that easy way of documentation, easy way of analysis, easy way of writing the paper, scientific paper is not easy even today. Should there be 1 month minimum statistics idea, whatever the statistics, how to document first? What should be the parameter should be put, Excel sheet, vertical column, horizontal columns, all these things. If they are not trained in surgery, should this be included as an exam for first 3 months, so that after the passing, so that by forcibly they will get adopted? Otherwise everybody will be looking for surgery, and they get tempted only to do surgery.
Yeah.
How to, some students are naturally talented, they will write it, but the percentage of those students are less. So
Yes.
my colleagues like Dr. Pankaj, Niranjan, Shabir, we are all very good. We are doing surgeries, but somehow, unless the teamwork is there, this year only I made 5 papers. Otherwise, 15 years I could not make much, even though I was doing a lot of stone surgeries. Where we were lacking, those who are in UK, when they come back to India, they write papers easily. But we are not able to push. I mean, attitude is one matter, but any other thing we can improve, sir.
Dr. Chandramohan, I like to emphasize those students who like to choose their career in academic urology. They have to focus on these, because they have to do scientific work, they have to write research work, they have to write review article, systemic review and meta-analysis. Only then they will get some value. And elementary statistics is a modular course here, which is taught to during the MS career.
Yeah, sir.
Elementary statistics should be part of, and every student has to qualify for that.
Yes, sir.
So that should be there. So again, I say that if I am allowed to propose an updated curriculum for the urology during these 6 years, research paper writing, systemic review and meta-analysis writing would be part, and therefore they will be learning the basic statistical methods and processes needed for such analysis.
Yes, sir. Yes, sir. The other aspect in PGI Chandigarh where we were there is a chief senior residency program and an exam MCH 6 months before. Who was introduced? Why it was introduced? We felt that it is a luxury for the resident to do so many surgeries and learn the administration, and also by chance if you fail, you don't lose 6 months. Whose idea is it and how it is implemented? It is really helpful, sir. I don't know how institutes have this, but PGI has.
Okay. When the MCH course was made to 3 years course from 2 years, so there was a proposal that there was a particular column that when we want to hold the exit examination.
Yes, sir.
I was involved at this stage.
Sir.
So we had a departmental meeting and discussed with Professor Sharma and others. I think Dr. Singh also was part of that in that time. So we said that if we hold the exam 6 months before the end of the schedule completion of curriculum, the students after passing get these 6 months and he can be posted into his area of choice. Like in PGI, there was hardly any exposure to pediatric surgery or transplant. So my intention was that. So one intention was that to give a chance to the student to choose his area of interest and work some exposure there. The other thing, I had seen students failed at the end of MS examination. And the MS examination was conducted at the end of their training. So the student's status become horrible. He becomes out of contact. He goes back to his place. He comes back again for the exam. So I said, if by chance somebody fails these 6 months, he gets a chance to improve and he becomes a part of the training. There was problem also. Many students after completing the examination, the last 6 months, they would not show interest to work. That also happened. So many faculty had written letter to the dean saying that the exam should be held at the end of 3 years. So Dean PGI had done a survey of all the DM and MCH courses. Majority opinion was no, that this is helpful.
Yes, sir.
At 2.5 years and 6 months are given to the patient, given to the students for their benefit. I must say that with the introduction of the robotics, the last 6 months, PGI, 2
Yes, sir.
months are posted in the emergency.
Yes, sir.
2 months they are chief resident. 2 months they are posted in the robotic surgery. So in PGI, things are working very well.
Yeah.
And the students get ample exposure. They go with confidence. They say, even we know robotics.
Yeah.
Now I will come back to your question of chief residency. The chief residency in medical training is a well-known part. It is there even in medicine specialties abroad, anywhere. So chief residency has been introduced in PGI. Velour में क्या होता है? From the very beginning.
Sir.
With the 3 years course and the number of patients and 2 units, the chief residency has extended to 4 months, 2 months, 2 months. 2 months they do before their MCH examination and 2 months they do after completing the examination. So that gives a lot of chance, and I will say this is an advantage. Yes, it may sound to be luxury, but it is benefit to the student.
Yes, sir. Sir, one more system change in US. The student will enter with professor. With his student will enter the professor and attach to the professor according to his subject. Once after 1 year, professor will say whether he is fit or not, and students also will say whether I am fit for the profession, and then he will continue, and then he will write the exit exam. That means every student has right to choose his profession. Here it is not like that. NEET first ranker will take radiology, NEET 10th ranker will take, even though he is not interested, pediatric surgery is something else. Whereas DMB, you can join. What do you think, sir? For example, somebody is interested in urology, did not get 3 times urology, he will go to neurosurgery and decide his fate. But in US, it is not like that. After MBBS, they can join any fellowship program with any professor with some of his background and interest. So joining with interest, then proving that you are a hardworking student, and then going to heights is one way. Otherwise, join whatever God decides and then become excel in that. There is a lot of difference in this. What is your opinion, sir?
My opinion is very clear. The choice of the candidate and his ability is an important determinant. Like our MS examination and MCH, we were asked which subject are you appearing. It's not open.
Yes.
Right. So therefore, these days, because the entrance system has changed a lot and it is undergoing change, now it has become purely theory based. That's also a problem. We used to have an interview to know the candidate, to know his interest. I'm not sure that I'm very sure this is not a very good system. At least for the super specialty areas, this is not a good system.
Yes, sir. They should work and develop interest, and then
they should develop a test. They should develop a test and then they choose to work in that.
Yes, sir. Now, coming to the institutions, government institutions, for example, if it is related to the flexible ureteroscopy, that is a costly equipment. One flexible scope and one laser will be sanctioned with difficulty. And if by chance any problem arises, if the administration and the head of the department and the consultants does not impress, cannot impress, or cannot get the equipment back, these type of costly equipments maintenance becomes a problem in government institutions. Then naturally that subject gets deviated. Prestigious institutions, if they are not able to do some of these surgeries which involves high tech, especially in urology, it is costly equipment. So coming down the line, the private institutions are buying and doing with DNB better. Then where are the AIMS and Chandigarh, all the ZPJ, CMC, whatever it may be institutions, people will get best rank and they take in those institutions. How they have to see in that angle. Yes, traditional training, good teachers, lot of ethical environment will be there. But what if they have not touched even flexible scape once in their career, then how will they go and do practice in stone surgery outside?
First of all, I must say, Dr. Chandramohan, when you did your training, you did semi-rigid uteroscopy, you never touched a flexible uteroscope. But
Yes.
you have the basic exposure, you have your basic knowledge of the anatomy and everything, as you were emphasizing.
Yes,
So
sir.
therefore, all costly equipments cannot be given freely to for multiple handling. It's difficult because in government there are many rules. First of all, the fund matters. Second, if the equipment is bought, if this is not utilized, that also matters. If it is broken before a minimum period of service, that also becomes a problem. So there are many problems. Therefore, these exposures have to be limited. But once you know the basic things, possibly you can develop. That's why I was saying that given a chance, we keep 1 year at the final for his fellowship, his area of interest. If you want to manage stones, so he knows he does only stones, everything he does stones. He goes out. If you want to do oncology, he does oncology. So we have to make a balance in some place.
Yes. Sir, I wanted to comment. Now I am also 17 years into the private practice. To answer this question extended, when I was finishing my MCH, I did not have flexible scopy and laparoscopy. But I do, with due respect, Dr. S.K. Sharma sir, Dr. Mandal sir, Dr. Goswami sir, Dr. S.K. Singh, and Dr. Uttam sir, they have trained what damages the ureter, what damages the urethra, what is the pressure, and how small it is, and how guide wire slips in PCNL. When at that time consultants were getting trained, we are not. So that helped in our career. That is my opinion I want to give. It is not my talk today, but as you said, sir, later on these basics, we can develop whatever we want depending on the situation and availability and where we join, either private or government. So I still feel institutions, those residents who are joining should never think that one equipment was not there, and the amount of the teaching on the basics like Foley's catheter maintenance, dressing of Foley's catheter, catheter blockade, trauma, role of SPC diversion, role of PCN, ultrasound guided PCN emergency have helped in our career a lot, sir. Just a comment.
Yeah.
The last
I
couple.
appreciate that.
Yes, sir. I am very happy for that. There are occasions when the guide wire is removed from the PCNL track, we used to get discrubbed. We used to feel bad. But when the hypospadias wound encrustations were there, we used to feel bad. But we realize the importance of that now in private practice. Even now, that is helping in whatever surgeries we are doing. So number of surgeries should not be taken. How many number of PCNL you have done? How many number of RIRS you have done? Should not be a major obstacle for the aspiring young urologist after MCH is our gut feeling, sir. Because we faced that, and now we are able to do all type of surgeries. Coming to the last couple of questions, in the future, this America, if you see AUA journals, hardly any surgical based journals are published now. They are going into the genetics, molecular genetics, and experiment on the mice, and discovering new things with the chemical molecules, which will in fact may decrease the role of surgery also sometimes. Like in BPH, at least 50% are managed now after the failure of medical management. And so a lot of focus is there on prevention, lot of focus is there on research on molecular level. Do you think, recently I have seen in Chandigarh also, are you involved in such type of research? What type of expenditure and budget is required for such activities at genomic level?
There is a proposal going on to develop a molecular laboratory
Sir,
here in AIMS Rishikesh.
sir,
But the fund crunch is problem, In the last 2 years, the proposal is practically in the cold storage because of the COVID, and all the funds has gone to COVID management and other things. So fund is a problem, but that is the way forward, Dr. Chandramohan. If you have got a medical treatment for a disease, nobody will like to undergo surgery if the results are good.
yes, sir.
So therefore, it is important, no doubt about it. Research is always important.
Research is always important. Sir, last question I wanted to ask. In the coming years, what is in your mind to take certain measures, if at all you wanted to take certain measures in the country level? Because all HODs at the one point of time at your stature will be called for the amendments, for the changing in the teaching schedules. Are you planning anything at your will in Rishikesh, like chief residency or 1 year before? Do you have any ideas so that the students get benefited, assistant professors get benefited? What should be the senior junior relation in the institution? How many seats should be taken? This is the last question, sir. How the urology training coming 10 years should be actually, and how it will be?
See, the training in a particular center has to depending on the training facility. By training facility, I means the amount of workload, the quantity of exposure the student would get, the number of faculty the department has got, like that. The seats should not be increased arbitrarily, which the government is doing these days. Suddenly now it is the number of seats. But here we try to restrict it.
Okay.
Number two, I must say that the curriculum of urology training is a time for revision. We are late actually. The field has become very vast. Specialization has come. Everybody wants expert service. So therefore, the students' training curriculum need to be updated and changed. We are really debating of starting MCA's training program in urology soon after MBBS. Maybe 1 year time will spend for them training them in general surgery in the 3 areas I said: wound management, trauma and emergency, and critical care. They don't need to get exposure to thyroid and all other things. They will spend 4 years in urology. At the end of 5 years, they will take their exit examination. They qualify, and 1 year I will suggest to keep it for their own area of interest. That is it.
The assistant professors also, should they confine to one field so that they can train the students better? Because anyway 4 or 5 assistant professors, additional professors will be there. Should they also concentrate than focusing on only crazy thing, and they can help the next generation better with research as well, papers also?
The department should make informed decision among the faculty and choose areas to develop. Now, you cannot develop all the 6-7 areas of urology in one particular center. Maybe you do good work in 3 areas: uro-oncology, stone disease, reconstruction. That will be fine. So the faculty member should choose and work in that area. For that, they should be encouraged. They may go for fellowship. This is fine. But general, like my age has practically gone. We were made to do everything. I was made to do stone surgery, tumor surgery, and reconstruction for infertility. No, it is not possible.
Yeah. So you already did in Chandigarh, divided the units into two. That is the first work you have done, because we were in a single unit, so that both units are rotated and both units have different sets of patients. Their mode of going into the unit itself is decided by the patients, if not by the surgeon. Automatically, those type of surgeries are more done in that unit. And this we have not witnessed. We came to know through the juniors that two units, and but students get a rotation chance, so that they need not get biased and they need not get attached to only one thing. So
Yeah, they get
they get
exposed to everybody.
yes, sir. So with this, even though there is some connectivity issue, I will for the audience, I will edit the by tomorrow and give a fresh link. Little bit of connection was problem, voice was little breaking, but from my heart I wanted to conclude with the permission of Dr. Mandal sir. I wanted to talk for 3 minutes emotionally to conclude. Dear urology juniors, particularly, we entered into the second era or third era of the urology in 1998 from my MS training. In relation to my colleagues, I am telling this. We were preparing like all of you. We have had tough time, rejected in certain institutions because of lack of experience in the MCH level. Then we entered this prestigious institute, PGI. At that time, we used to compare with advanced institutions and then feel that laparoscopy is not there in, it is there in AIMS, and they got robot and we got this, that was there. But what I remember deeply at this point of time, after 17 years and having some teaching program under our curriculum also, we feel that please and please focus on the concepts and principles. Even I may be missing many times. Dr. Mandal sir and Dr. Goswami sir used to curse on us not reading the basics. That is the first few chapters of the Campbell we always miss. So even I remember Dr. Mandal sir reading radical nephrectomy steps in the morning 8 o'clock and then coming at 9 o'clock and asking us, and doing same thing for years, is for the improvement and betterment of the patient. I strongly feel this essential component of anatomy, physiology, and concepts of diversion, sepsis, tubular. They used to tell that ureters are not tubes; they are structures. Respect them, and they used to tell that every part of the tissue must be respected. Especially Dr. Mandal sir doing hypospadias and radical nephrectomy, particularly the way he was demonstrating with the right angle and the forceps, dissecting few layers on the vein and making the vein nude and encircling by the side with right angle dissection, hooking it, and then taking 3/0 silk and separating at least 1 centimeter and then tying and then carefully cutting, not hurriedly. There was a time Professor Studer demonstrated radical cystectomy with lymphadenectomy. Similar type of surgeries we have seen in radical nephrectomy. I really doubt with energy sources whether we can do such meticulous surgery, even to the extent of not benefiting the patient with cautery and bipolar. One must go through these type of training, especially open surgery, meticulous dissection, and postoperative principles have helped us a lot, not only in practice, but today what we are earning money also is because of those principles. Many think that we tell what surgery and then promote. It is not the correct. We have not done enough PCNLs during our training. We have not seen the laparoscopic surgery. We have not learned the suture. But only thing we remember is not to damage the patient in which condition he has come. I have done one avulsion during my pyelolithotomy. 110 times the Gilvernet fascia is discussed in our journal club, so that I remember Gilvernet fascia every time I go nearer to pelvis, whether laparoscopically or open surgery. Even as a matter of fact, I will be remembering if I am doing PCNL also that fascia. That type of training is available in traditionally government institutions. We all pray that teachers like Dr. Mandal sir should continue their teaching and maintain this traditional teaching. I waited 9 months for this talk So that I wanted to ask these things from experienced persons who are 40 years in the teaching, so that all the juniors should not be in hurry for anything. Just stand with your professor, learn in your institute whatever the best you can learn. Later on, you can mold the career. Thank you, Mandal sir, for giving patient time. I am very, very happy. I will remake for the audience this YouTube link again tomorrow and then release so that it will be a document forever.